Good afternoon, my name is Bree Carter and I'm from the Pharmacy Department at Erlanger. I'm the Trauma and Surgical Critical Care Clinical Pharmacist, and today I'll be talking to you about multimodal pain management strategies, and I'll also be discussing acute pain management in patients undergoing medication-assisted therapy for chronic opioid dependence. So today I'll be talking about multimodal pain management, and some of the objectives of this presentation are to be able to develop a multimodal pain regimen for a patient with traumatic injuries, and to be able to formulate an acute pain management plan in a patient undergoing chronic treatment for opioid abuse. I'd like to start out with a little background information and discuss why this topic is so important, especially in the trauma population. Up to 50 to 60% of trauma patients experiencing chronic pain from trauma 1 year after injury. Some of the identified risk factors for chronic pain after ICU discharge are high pain intensity, uncontrolled postoperative pain, and a long pain duration. Pain has multiple adverse effects that are listed on your screen. Therefore, it's extremely important that pain management is a central part of care for patients with traumatic injuries. Opioids have remained a mainstay of treatment for acute pain management, but their prescription for chronic pain has increased over the last 30 years. The opioid epidemic was declared a public health emergency in 2017, and the government has recently taken a lot of measures to help decrease opioid use in the last 5 years. In 2018, Tennessee had the third highest opioid prescribing rate in the country. At that time, there were 81.8 prescriptions per 100 persons, compared to the U.S. rate of 51.4 prescriptions per 100 persons. In 2019, there were over 5.3 million prescriptions written for opioids in Tennessee. While we continue to use opioids to treat acute pain, opioid use greater than 7 days increases the probability of chronic opioid use. We can utilize a multimodal pain management strategy to minimize the use of opioids. This strategy of using multiple medications with differing mechanisms of action is considered standard of care and is supported by multiple different professional organizations. Now we'll move into talking about the different medication classes that can be used in a multimodal pain management strategy. First, we will start with cyclooxygenase inhibitors. These drugs work by inhibiting pain signal transduction at nociceptor sites by reducing prostaglandin synthesis. Based on this mechanism, initiation of NSAIDs prior to the release of inflammatory mediators may improve their analgesic effects. Salicylates do technically inhibit cyclooxygenase, but are typically used as an antiplatelet in patients with cardiovascular disease rather than for pain management. Therefore, they will not be discussed for the purposes of this presentation. Acetaminophen is a central COX-2 inhibitor and has been shown to decrease opioid requirements in surgical and trauma patients. Acetaminophen can cause hepatotoxicity, and dosing is typically limited to a maximum of 3 grams per day. Acetaminophen is available as oral tablets and solutions, suppositories, and as an IV injection. The use of the IV formulation results in similar clinical outcomes such as opioid consumption and pain scores. Given the very drastic difference in price between the IV and oral and rectal formulations, many hospitals do not carry or severely restrict the IV formulation. Therapeutic effects of NSAIDs occur during the inhibition of COX-1 and COX-2, which prevents the conversion of arachidonic acid to prostaglandins, thereby preventing sensitization of pain receptors in response to tissue injury. The inhibition of COX-1 results in decreased prostaglandin, specifically PGE2 synthesis, which in turn causes decreased gastric mucus and bicarbonate secretion, and decreased blood flow. 10 to 30% of patients on NSAIDs have evidence of endoscopic ulcers, and serious ulcer complications occur in up to 1 to 2% of patients. PGE2 also controls some osteoblast activity, and therefore there has historically been a concern that NSAIDs can inhibit bone healing. Inhibition of COX-1 can have adverse renal effects. When normal renal function is impaired, such as in advanced age, patients with heart failure or kidney failure, prostaglandin synthesis is upregulated to cause vasodilation of the afferent arteriole in the kidney. When NSAIDs are then given, this results in the constriction of the afferent arteriole, which decreases blood flow through the glomerulus and increases the risk of acute kidney injury. COX-1 inhibition also results in decreased production of thromboxane A2, which results in platelet inhibition and vasodilation. COX-2 inhibition results in decreased production of prostaglandin I2, which results in vasoconstriction and platelet aggregation. The effects that NSAIDs have on PGI2 inhibition are responsible for the cardiovascular associated side effects that are seen with NSAID use, specifically stroke and MI. The FDA has placed a black box warning on all non-aspirin NSAIDs for increased risk of heart attack or stroke. The arrow at the bottom of the slide represents the degree of COX-1 and COX-2 inhibition of some of the commonly used NSAIDs. As you can see, ketorolac has much more COX-1 selective inhibition, whereas celecoxib is considered COX-2 selective. This is important to remember when assessing the side effect profile of these different agents. Orthopedic injuries are very common in trauma patients, so I'd like to briefly discuss some of the data regarding the use of NSAIDs in this population. A meta-analysis was conducted to determine whether the use of NSAIDs increases the risk of delayed union or non-union in the setting of fracture, osteotomy, or fusion surgery. In the pooled analysis, which included a total of 15,242 bones, of which 3,283 were exposed to NSAIDs and 11,959 were not, a total of 512 cases of delayed union or non-union were reported. Of these, 226 had been exposed to NSAIDs and 286 had not, which resulted in an odd ratio of 2.07 with a 95% confidence interval of 1.19 to 3.61. Indicating a statistically significant risk of delayed union or non-union with NSAID exposure. A subgroup analysis was done in pediatric patients, which is depicted in the figure on the left, and this did not find a statistical significance in the pediatric population. The center figure depicts the subgroup analysis of just adult patients, demonstrating that there was still a significant difference seen in adult patients. Another subgroup analysis was done that specifically assessed the risk in patients who received low dose or short durations of NSAIDs, which is depicted in the figure on the right. And the authors did not find a significant difference in delayed union or non-union in these patients. Of note, low dose was defined as a dose of less than 125 milligrams per day of diclofenac, less than 150 milligrams per day of indomethacin, or less than 120 milligrams per day of ketorolac. And really, when you look at these doses, these are fairly high doses and typically higher than what we usually use in practice. The short duration was also defined as less than 2 weeks of treatment. I would also like to briefly review some of the literature regarding the use of NSAIDs in patients undergoing colorectal surgery, as trauma patients will sometimes undergo surgery for bowel-related injuries. Prostanoids play an important role in wound healing by triggering the inflammatory phase and regulating fibroblast function and mucosal regeneration. Therefore, there is concern that NSAIDs may impair wound healing of bowel anastomoses, increasing the risk of anastomotic leak. A meta-analysis was done in 2018 that included 17 studies. The median anastomotic leak rate was 5.4% with a range of 0 to 12.2%. Analysis of all studies did show a significantly lower rate of anastomotic dehiscence in those who did not receive NSAIDs. However, there was evidence of statistical heterogeneity with publication bias. A subgroup analysis was conducted of just the randomized controlled trials, and they found no significant difference in anastomotic leaks between the two groups. Another subgroup analysis was conducted to determine if selective or non-selective NSAIDs increased the risk of anastomotic leak. Non-selective NSAIDs, which is depicted in the bottom figure, were associated with a higher risk of anastomotic leak compared to those who did not receive NSAIDs. The top figure depicts patients receiving a selective NSAID compared to no NSAID, and there was not a significant difference seen between these two groups. So based on this information, if you choose to use an NSAID in patients that have had colorectal surgery or bowel surgery, it may be safer to choose a selective NSAID. The analgesic effects of NSAIDs are comparable, but as I mentioned previously, the side effect profiles are not. The risk of NSAID-induced GI adverse effects doubles every decade after the age of 55 years. Ketorolac has a 14.5-fold higher relative risk of gastric ulceration compared to ibuprofen. Studies have also evaluated the analgesic efficacy of ketorolac 10, 15, and 30 milligram doses and have actually found similar analgesic efficacy with all of the doses, suggesting that there is a ceiling effect at a dose of 10 milligrams. Higher doses of ketorolac may increase the risk of adverse GI effects without any added analgesic benefit. The next class of medications that we will discuss is NMDA receptors, or N-methyl-D-aspartate receptor antagonists. For the purpose of this talk, we'll focus on the utilization of ketamine, but for completeness sake, I'd like to mention that multiple other agents work as antagonists at the NMDA receptor. Drugs such as magnesium, dextromethorphan, memantine, and amantadine all have been studied in pain management, but many of these studies with these agents are small and they lack strong evidence to make recommendations about their use for pain management. In patients with chronic pain, ketamine helps to reverse central sensitization and enhances descending modulatory pathways. But in acute pain, ketamine's antagonism at the NMDA receptor and direct antagonism at mu-opioid, muscarinic, monoaminergic, and GABA receptors produces analgesia. When given at subanesthetic doses, ketamine does not cause respiratory depression. And the emergence of delirium people are commonly concerned about is seen more commonly when using the anesthetic dosing. Ketamine use should be avoided in patients with severe cardiovascular disease or uncontrolled hypertension. It increases systemic catecholamine concentrations by inhibiting reuptake, which causes an increase in heart rate and blood pressure unless the patient is catecholamine deplete, in which cases it will actually cause hypotension. Ketamine should also be avoided in patients with moderate to severe hepatic dysfunction, as it's been shown to be hepatotoxic when given for long durations. In these patients, a single bolus dose would be acceptable, but I would avoid continuous infusions for pain or sedation purposes. There are multiple studies investigating ketamine for pain management. This was a double-blind, single-center, randomized pilot trial looking at differences in opioid use in non-intubated trauma patients who were receiving a hydromorphone PCA compared to a ketamine PCA. The algorithm on the right depicts the dosing escalation and de-escalation protocol that was used. Hydromorphone PCAs were started at a dose of 0.2 milligrams with a 6 milligram lockout, and ketamine PCAs were started at 3 milligram dosing with a 6-minute lockout. Dosing of the PCAs could be escalated based on pain scores or de-escalated based on incidence of somnolence. Both study groups had hydromorphone 0.5 to 1 milligrams IV push every 2 hours as needed for uncontrolled breakthrough pain. And the primary outcome that they assessed was the daily breakthrough opioid dose requirements. Authors found no difference in breakthrough opioid requirements on days 1 through 3, but as expected, there was a significant difference in total opioid use. There was also no difference in pain scores between patients who received a ketamine PCA compared to those who received a hydromorphone PCA. This study supports the use of ketamine for pain management as an opioid-sparing technique and provides an unconventional method of administration that could be considered for future use. I'd like to take a few minutes to talk about ketamine use specifically in patients with traumatic brain injury. Ketamine use in patients with TBI or in patients who are at increased risk of elevated intracranial pressure have historically been considered contraindicated. There are conflicting studies examining the effects of ketamine on intracranial pressure. A few small studies done in the 90s have reported small but statistically significant increases in ICP 2 to 30 minutes after a bolus dose of ketamine was given, where the ICP rise was anywhere from 1 to 5 millimeters of mercury, with no difference seen in cerebral perfusion pressures. There have also been 2 double-blind, randomized controlled trials investigating the use of prolonged ketamine and sufentanil infusions, and these studies have found no difference in mean daily ICPs or CPPs. Ultimately, there have been no published studies that have reported sustained changes in ICP or CPP in neurologic outcomes, ICU length of stay, or mortality when using ketamine in a patient with a traumatic brain injury. Therefore, ketamine use in this population is no longer considered contraindicated. Next, we will discuss the use of gabapentinoids, antidepressants, and anticonvulsants and their role in multimodal pain management strategy. Gabapentin and pregabalin bind to noradrenergic alpha-2 delta subunits of presynaptic calcium channels in the dorsal horn of the spinal cord. This results in a decrease of excitatory neurotransmitter release and inhibits transmission of the pain signal. These drugs are approved for use in post-herpetic neuralgia, diabetic neuropathy, restless leg syndrome, partial onset seizures, fibromyalgia, and spinal cord injury. In studies assessing the efficacy in the perioperative setting, gabapentin and pregabalin have demonstrated efficacy in decreasing postoperative pain scores and opioid use within 24 hours after surgery. Pregabalin has also been shown to decrease the incidence of postoperative nausea and vomiting. In studies that continue these medications for longer than 24 hours postoperatively, there's been conflicting data on efficacy. I've provided some common dosing regimens for these medications when used in the perioperative, postoperative, and chronic setting, but there have been a wide range of dosing regimens reported in the literature. Remember that these drugs can be sedating, and lower doses are recommended in the elderly and patients with renal failure. Serotonin and norepinephrine reuptake inhibitors, or SNRIs, and tricyclic antidepressants work by inhibiting reuptake of serotonin and norepinephrine at the synapse along the descending spinal pain pathways. These agents are generally not used for treatment of acute pain because it can take weeks to see any clinical effects. It's also important to note that TCAs are on the Beers criteria and should be avoided in the elderly population. Drugs such as carbamazepine and oxcarbazepine may improve neuropathic pain by inhibition of sodium channels. It's postulated that irritable nociceptors result in upregulation of these sodium channels. Oxcarbazepine is typically preferred over carbamazepine, as carbamazepine has a worse adverse effect profile and multiple drug interactions. 2 Cochrane systematic reviews have been completed in the last 10 years investigating the efficacy of these drugs, and currently there is insufficient evidence to recommend these for first-line use in a multimodal pain management regimen. Next, we'll briefly discuss the use of sodium channel blockers. These agents inhibit the influx of sodium ions in neuronal membranes, decreasing the neuronal action potential transmission. Bupivacaine and ropivacaine are commonly used local anesthetics and may be combined with opioids, such as with opioids clonidine, dexmedetomidine, ketamine, and ketorolac. Studies have found that thoracic epidural and perivertebral nerve blocks can help relieve pain in patients with multiple rib fractures. Femoral nerve blocks and fascia iliaca blocks have been shown to improve pain and mobility in patients after hip fractures, and transversus abdominis plane blocks, or TAP blocks, help anesthetize nerves of the anterior abdominal wall and have been found to be efficacious in laparoscopic surgeries. Unfortunately, there can be multiple roadblocks to regional anesthesia. Most of these blocks require specially trained anesthesia personnel to be placed, and anticoagulants and antiplatelets typically need to be held before the procedure. Lidocaine is another sodium channel blocker that can be used for pain management. When given intravenously, it does not reach high enough concentrations to block sodium channels in the nerve or tissue fibers. With this route of administration, lidocaine works by decreasing pro-inflammatory cytokines. It inhibits NMDA and downregulates nuclear factor kappa B. In 2018, a Cochrane review evaluated the use of IV lidocaine and could not conclude clearly whether lidocaine had a beneficial impact on pain scores in the early postoperative phase, in GI recovery, in postoperative nausea, or in opioid consumption. There are conflicting studies regarding the efficacy of lidocaine patches, reducing pain scores, narcotic usage, and hospital length of stay. Lidocaine patches have a very low side effect profile, so it may be reasonable to consider this treatment option. Muscle relaxants are utilized for spasticity and local musculoskeletal spasms. There are multiple different agents available with differing mechanisms of action. Prior to choosing a muscle relaxant, it is important to determine if the patient is experiencing spasticity or spasms. Spasticity is a disorder of motor neurons that manifests as increased muscle tone and stiffness. It can present as stiffness, hypertonicity, and/or hyperreflexia. This is often seen in patients with spinal cord injury and traumatic brain injury. Spasms are involuntary localized muscle contractions that arise from acute trauma or muscle strain. Spasms are typically characterized by jerks, twitches, and/or cramps. This is not an all-inclusive list of available muscle relaxants, but represents the most common agents used in clinical practice. Diazepam and carisoprodol have limited use in multimodal pain management protocols due to their potential for psychological dependence and the risk of withdrawal and sedation, especially when used in combination with opioids. Baclofen works by inhibiting pre- and postsynaptic GABA B receptors and can be given either orally or intrathecally for spasticity associated with brain and spinal cord injuries. Tizanidine is a central alpha-2 agonist used specifically for spasticity and has also been found to significantly improve pain scores after inguinal hernia repair. Cyclobenzaprine reduces tonic somatic motor activities, affecting the gamma and alpha motor neurons and thus decreasing muscle spasm. When evaluated in combination with NSAIDs, cyclobenzaprine was not actually found to provide significant improvement in pain intensity compared to NSAIDs alone, or in patients that had C-spine strain after a motor vehicle accident or a fall. Data for use of methocarbamol in trauma patients has produced mixed results, but when utilized in patients specifically with rib fractures, does appear to be a benefit. This was a retrospective cohort done at a level 1 trauma center that included adult trauma patients with closed rib fractures. They compared time to hospital discharge in patients who received methocarbamol and those who did not. The authors found that patients receiving methocarbamol were significantly more likely to be discharged home sooner and were also less likely to develop pulmonary complications such as pneumonia or atelectasis during hospitalization. Now I'd like to switch gears to discuss acute pain management in patients taking chronic opioids. Remember, there were over 5.3 million opioid prescriptions filled in Tennessee in 2019, so most healthcare professionals are likely to encounter patients receiving chronic opioids. Several studies have demonstrated that opioid-dependent patients have a four-fold increased opioid requirement in the postoperative period compared with opioid-naive patients. In addition, the duration of postoperative treatment is about 3 times longer in these patients compared to opioid-naive patients. Before I talk about recommendations specifically in this population, I'd like to briefly talk about the phenomenons of opioid-induced hyperalgesia and central sensitization. Opioid-induced hyperalgesia is a paradoxical response where patients receiving opioids can become more sensitive to painful stimuli and will experience more diffuse pain. In these patients, increasing opioid doses can actually worsen the pain. One of the leading theories as to why this occurs is due to the availability of glutamate to the NMDA receptor. This activation at the NMDA receptor results in the development of central sensitization. Some treatment options that have been offered for treatment of these phenomenons are opioid rotation in the acute setting, and for chronic patients that have this down titration of opioid dose over time, and then the utilization of a multimodal pain approach. Utilizing medications that are NMDA receptor antagonists, such as ketamine and methadone, may also provide some benefit in these patients as well. So some general considerations and recommendations for treatment of patients who are on chronic opioids include continuing their home medication and dose to provide and maintain the patient's baseline pain coverage. This obviously can be difficult to do in patients taking illicit opioids such as heroin and street fentanyl formulations. In situations that afford time for preoperative planning, consider administration of preoperative multimodal analgesics such as acetaminophen and/or NSAIDs. Consultation with anesthesia regarding regional anesthetic options is very important, and discussing the pain management plan with the patient and to help manage their expectations. It's also important to coordinate your discharge pain management plan with their patient's outpatient provider who's currently managing their chronic pain. And you can also consider opioid rotation. The last topic that we'll be discussing is acute pain management in patients receiving treatment for opioid addiction. According to Health and Human Services, currently upwards of 1.27 million people are receiving medication-assisted treatment for opioid abuse in the United States. The first medication assistance treatment we will discuss is methadone, which is a synthetic opioid agonist and NMDA receptor antagonist. It's important to obtain patients' home dosing regimens so baseline dosing can be resumed. It's also important to note that methadone clinics do not report to controlled substance monitoring databases, and the clinics must actually be called in order to obtain accurate dosing information. When methadone is dosed once daily, it's being used for methadone maintenance treatment for opioid dependence, whereas when it's used to treat acute pain, methadone must be given 3 to 4 times a day in order to provide adequate analgesia. Methadone does cause significant QTC prolongation, so caution should be used when prescribed with other medications that also prolong the QTC interval. Doses should not be titrated more often than every 5 days, and a special DEA number is actually required in order to prescribe methadone for opioid addiction. If you're just continuing an outpatient regimen in the hospital or using it for pain management, a special DEA number is not required. Acute pain management in these patients should consist of continuing their home methadone dose, providing adjunctive opioids to treat the acute pain, and then multimodal options that we have previously discussed. The next medication-assisted treatment we'll touch on is buprenorphine. Buprenorphine is a semi-synthetic opioid analgesic that binds to mu, kappa, and delta opioid receptors with slow dissociation, which results in a long duration of action. It has a high affinity for the mu receptor binding and displaces other opioids competing for that binding site. It's used for treatment in opioid addiction, chronic pain management, and opioid-induced hyperalgesia. Some dosage forms are combined with naloxone to deter abuse potential when it's injected. When naloxone is given orally, it's actually rapidly inactivated via first-pass metabolism in the liver and does not negate the effects of opiates. Buprenorphine is available in multiple different dosage forms that are listed on the screen, so it's important to assess the dosage form the patient's taking and consider the half-life of that dosage form. In patients that are having elective surgery, buprenorphine can be discontinued 72 hours preoperatively, and the patient can be converted to a full opioid agonist preoperatively. Unfortunately, in the case of trauma, we don't always have the luxury of time, and these patients typically still have buprenorphine in their system when they reach our hospital. There are a couple of different approaches to management in patients taking buprenorphine that present to the hospital, and one approach is to completely discontinue the buprenorphine and to initiate methadone in addition to multimodal options that we've previously discussed. Buprenorphine would then need to be resumed when the patient has not been receiving opioids for at least 5 to 7 days. This transition back to buprenorphine would typically be done by the patient's outpatient provider. Another approach is to continue the patient's current buprenorphine regimen and treat acute pain with pure opioid agonists, in addition to the previously discussed multimodal options. This treatment strategy may require the use of high doses of opioids to overcome the effective buprenorphine, but this approach is the preferred management option because it doesn't actually require that the patient be opioid-free for 5 to 7 days because they haven't ever discontinued their therapy. Naltrexone is the last medication-assisted treatment that we'll discuss. Naltrexone is a pure opioid antagonist with the highest affinity for the mu receptors. It's used in alcohol and opioid-dependent patients. There's two different dosage forms available that have drastically different half-lives. The oral dosage form has a much shorter half-life, 10 to 13 hours, but is not frequently used due to issues with patient compliance. Patients receiving the monthly injection can be extremely difficult to manage given the long half-life of the drug. In patients receiving the monthly injection, it's very important to assess and consider when their last injection was actually given. Patients who have received their dose within the last 2 weeks are particularly difficult to manage and may be completely refractory to opioid analgesics. The longer you get out from the injection time, opioid antagonism may be overcome with high doses of opioids. Additionally, when you approach that 4th week from injection, patients actually may become overly sensitive to opioids because chronic opioid antagonism may result in an increased density of opioid receptors in the brain. These patients should be monitored very closely for side effects, especially respiratory depression. Ultimately, pain management in these patients is typically very difficult. Animal studies have suggested that opioid doses 6 to 20 times higher than normal may be needed to achieve adequate analgesia. Multimodal pain options are the mainstay of treatment in these patients. Careful consideration on the time of naltrexone resumption should be done by an outpatient provider trained in addiction management. These patients must be opioid-free for at least 7 to 10 days before naltrexone can then be resumed. So just to conclude some of the big points of this talk, multimodal approach reduces opioid consumption. Preoperative administration of acetaminophen, NSAIDs, and gabapentin or pregabalin can decrease postoperative pain and opioid consumption. Muscle relaxers are helpful for spasticity and muscle spasms. You should strongly consider ketamine and regional anesthesia options for patients with chronic opioid use. And it's really important if you have this available at your facilities to consult with pain management specialists for patients undergoing medication-assisted treatment for opioid addiction. I'll take questions in the question section of this blog.